Hi, my name is Bruno Breezy. I'm a creative coder and Hi, my name is Bruno Breezy. I'm a creative coder and Hi, my name is Bruno Breezy. I'm a creative coder and Hi, my name is Bruno Breezy. I'm a creative coder and Hi, my name is Bruno Breezy. I'm a creative coder and
Good day, everyone. It is my pleasure to welcome all in attendance, locally, regionally, and internationally, to this World Antimicrobial Awareness Week webinar on infection prevention and control against antimicrobial resistance. We can all agree that this is a very timely and important topic, given the morbidity and mortality that results from this problem. Please allow me to specially acknowledge distinguished guests from the World Health Organization, WHO, the Pan American Health Organization, PAHO, the Caribbean Public Health Agency, CARPHA, the World Organization for Animal Health, the Inter-American Institute for Cooperation on Agriculture, and the Food and Agriculture Organization for the United Nations. I would like to also specially acknowledge representatives from the Ministry of Health and Wellness, the Ministry of Agriculture and Fisheries, as well as the Ministry of Industry, Investment and Commerce, Jamaica. Special welcome to the leadership of the University of the West Indies represented here and the Department of Microbiology, as well as other distinguished guests. A warm welcome to you all. We're happy to have you all here as we host this webinar to explore the global impact of antimicrobial resistance, the impact of COVID-19 on antimicrobial resistance, basic infection prevention and control principles and practices, and strategies that can be deployed to break the chain of infection. Without further ado, let us begin. I will now invite Dr. Valesca Stempliuk from PAHO WHO to give us an overview of the World Antimicrobial Awareness Week. Dr. Stempliuk has a degree in nursing science, a master's in business administration of health systems, and a PhD in molecular microbiology from Sao Paulo University, Brazil. She is a specialist in evidence-based health and hospital epidemiology since 2005. She has been working at PAHO. She's a former regional advisor for infection prevention and control, and is now the disease surveillance prevention incident management support team member. She is a former regional advisor, to IPC, and is now disease surveillance prevention and control advisor at the PAHO office in Jamaica. She is part of the infection control team of the PAHO incident management support team for the COVID-19 response. She has vast international experience in the assessment of infection prevention, control programs, and the National Infection Control Program implementation and outbreak investigation and control. Dr. Stempliuk, over to you.
Thank you very much, Dr. Campos Rodriguez. Good morning, colleagues. My pleasure to be here with you this morning. I'm Dr. Valesca Stempliuk. I'm advisor for health surveillance, disease prevention and control here in PAHO WHO Jamaica country office. And I will start using this opportunity to thank our partners from government of Jamaica, many entities representing the government of Jamaica, the UN agency, the University of the West Indies for the partnership that make this week of celebration possible. I will also would like to thank especially the PAHO team, the team that we work together to do our part in this. So a special thanks for Dr. Campbell, Ms. Parks, Mr. Kidd, and Ms. Thompson for their support to organize and run this week of activities. So discussing or talking a little bit about this week of activities and why it is important. So I'm glad to see that we get together today to discuss infection prevention and control, but this is more than infection prevention and control and more than human health. Is a really joint effort to mitigate this problem. So we now globally continue our efforts to mitigate the effects of the COVID-19 pandemic and treat patients with COVID-19 demand increased use of antimicrobial antibiotics to treat their secondary infections. And we are expecting, and we are already see the effects that it's having in the antimicrobial resistance. So antimicrobial resistance refers a growing number of microorganisms for which the effectiveness of the antimicrobial agents in kill them or controlling their growth is declining. And it's real and it's happening right now in our lives, in our health services. With the limited number of new agents being developed to combat microbes, this is particular concern problem. Currently, at least 700,000 people die each year due to drug-resistant diseases, including 230,000 people who die from multi-drug-resistant tuberculosis. More and more common diseases, including respiratory tract infections, ear infections, sexually transmitted infections, urinary tract infections, are untreatable, and life-saving medical procedures are becoming much riskier because our inability to treat secondary infections and put in risk the patients who go under this type of procedure. The UN Agency Coordinating Group for Antimicrobial Resistance in 2019 have alerted all of us that if no action is taken, drug resistance could cause 10 million deaths each year by 2050 and damage the economy as catastrophic as 2008-2009 global financial crisis. By 2030, in few years from now, antimicrobial resistance could force up 24 million people into extreme poverty. So governments from all over the world have recognized the importance of the problem and that we have to do something now. Have joined force with agents such as PAHO, FAO, OIE to combat the problem together at animal, human, and environmental interfaces. Where in human health antimicrobial resistance is present in bacteria that include respiratory tract infections, many different types of healthcare-associated infections that we will discuss today, but also some forms of diarrhea and more and more simple infections that we could treat before. But multi-drug resistance is also important for diseases such as tuberculosis that we see in the community. And we know that if tuberculosis is caused by drug resistance, it will require treatment that are longer, less effective, and more expensive than those for no resistance tuberculosis. We have resistance in virals, so antiviral drug resistance is a big concern, especially for patients who are under treatment or long life treatment, such as patients with HIV. We also have drug resistance in malaria that may not be an important problem here in Jamaica. However, is a huge problem in other areas of the globe, such as Southeast Asia and Africa. And we have drug resistance in fungi, and we know that one of the emergence infection diseases is also caused by Candida auris, for example, that is reaching and causing outbreaks all over the American region. And it is a fungi that is resistant to most of the antifungal drugs that we have. So to face this big problem, we need to collaborate, and among all of us, we will be able to help spread the mandate for rational use of antimicrobials across all the sectors to develop our local, national, and international policies to govern the use of those agents, treatment guidelines, AMR surveillance, public education, infection prevention and control strategies in all sectors, and research and development of new agents to ensure continued capacity to treat infections well in the future. So the World Antimicrobial Awareness Week is one of the many strategies that all these organizations and the government of Jamaica is put together to face this problem. So since 2015, work leaders and experts in the field have met between November 18 to 24 to encourage healthcare workers, policymakers, and the public to put best practices in places to help the emergency and spread of antimicrobial resistance. PAHO WHO is promoting integrated surveillance, infection prevention and control, antimicrobial stewardship, quality and safety of the antimicrobial medications, and guiding research to make sure that all areas are covered. So as I mentioned before, we are very happy to partner with many other entities in promoting this week of celebration. We are having a week of seminars with experts from all over the island, and you are joining us from all different places as well to discuss the impact of the antimicrobial resistance in our day-by-day activities and how we can decrease or mitigate this problem. So we had an agenda that covered many topics for workers, human health, veterinarian, agriculture, environmental areas, but also for general public. We start on November 15 with the launch and the forum. Yesterday, we had the Agro Day, focused on the agriculture, food chain, and the impact of antimicrobial resistance have in this area of activity. Today, we are here to discuss infection prevention and control. And next week, we will discuss the regulation and prescription, public and private partnership, and antimicrobial stewardship. So you can find more information in PAHO WHO webpage and also different entities in webpage. So I'm here to invite you to participate, to pose your questions, to make comments, to spread the information and help us keeping antibiotic as a useful resource to fight infections. So thank you for joining us today. Thank you, partners who are part of this seminar today, who are part of this week of celebration, who will keep work together to mitigate the effects of antimicrobial resistance. Please share this information about the World Antimicrobial Awareness Week and also join us in other sections. Thank you, and I wish we all a very good week of activities. Thank you.
Thank you so much, Dr. Simply. What a wonderful way to start this morning's session. And you are already reminded that we will have the Q&A segment at the end. And so we encourage you to post your questions in the chat as we go along. I will now introduce our next speaker, Dr. Clindy Reynolds Campbell, who will speak to us about the global impact of antimicrobial resistance. Dr. Reynolds Campbell is a medical doctor who specialized in clinical microbiology at the University of the West Indies. She received these degrees there and later obtained a master's in public health from the University of Saskatchewan. Dr. Reynolds Campbell has an interest in all things microbiology, but has a special love for the area of mycology. She's a lecturer for the University of the West Indies and serves as a consultant microbiologist at the University Hospital, where she also functions on the Infection Prevention and Control Committee. Dr. Reynolds Campbell is also a consultant for PAHO Jamaica office in the field of infection prevention and control, as well as the field of antimicrobial resistance. Dr. Reynolds Campbell, the floor is yours.
Good morning, everyone. Okay, I'm hoping you can see the screen. Hi. All right, are you able to see my presentation?
Yes, we can.
Okay, great. So as Dr. Camila and Toms Rodriguez just told you, we're going to be talking a little bit this morning about the global impact of antimicrobial resistance. So we're going to just, mention exactly what is antimicrobial resistance, what are some of the effects, the causes, and the impact that it can have globally and locally, and what exactly is being done about this problem. So first of all, we know that antimicrobial resistance refers to that point in time when organisms, or you may call them bugs, most times we talk about just the bacteria, but just to remind you that there are several organisms that antimicrobial resistance can become a problem in. So it includes the bacteria, the fungi, the viruses, and the parasites as well. So when these organisms develop the ability to defeat or outrun or not be able to be killed by the drugs that were designed to take care of them, then we refer to them as being resistant. This is a worldwide public health threat. It's a problem for healthcare, it's a problem for food production, and ultimately, it can affect life expectancy. The WHO put out a statement which I liked, so I'm sharing with you, and it mentions a few things that, we should really bear in mind when we talk about this problem. It said, modern travel of people, animals, and goods means antibiotic resistance can easily spread across borders and continents. Therefore, collaborative coordinated efforts will help to slow the development and spread of antibiotic resistance and protect people. We talk about it sometimes and we don't recognize the fact that it is affecting people on many different levels through many different sectors. So if we're just focusing on one sector, then we would have missed the point altogether. Another thing we need to mention is that we use the terms antibiotic resistant versus antimicrobial resistant interchangeably. But I want you to remember that antimicrobial resistant is a broader term that refers to not just resistance to antibiotics, which would be a problem for just bacteria, but it refers to all antimicrobial agents, all agents that were created to get rid of bacteria, fungi, viruses, parasites, etc. So it's a very broad term. So what exactly happens? We know it can affect just about anyone at any age and in any country. It's not a rich country or a poor country problem, it's an everybody problem. It's a natural phenomenon that can occur, and it can be enhanced because we use our antimicrobials inappropriately. Overusing it, misusing it, all of that is inappropriate, and that can help to push and foster the occurrence of antimicrobial resistance. Persistent exposure will lead to selective pressure. So what happens is that we continue to feed basically the organisms with the antibiotics. The ones that are weak will die. The ones that can exist even in the presence of that antimicrobial agent is what we call they're selected for. So therefore, they're able now to just grow in larger numbers and become problems not just for humans, but we mentioned the animals as well. We also have a problem because new resistance mechanisms are popping up. They're emerging every day and spreading around the world. Again, travel makes it possible. These new resistance mechanisms threaten the ability to treat common gardener infections, as we call them sometimes. So there's less and less effective therapeutic options for infections, simple things like a pneumonia or tuberculosis, gonorrhea, and even salmonellosis. So therefore, it's a threat to modern medicine. Suppose it is that you have a hospital, you've developed a hospital, you have all the good technology, you can do your organ transplants, you can deliver your chemotherapy, you can do all the exciting surgeries. But if you can't treat the infection that may occur in those patients, then you have a problem. So no matter how progressed, no matter how advanced our health system becomes, if we don't deal with this problem, then it won't be helping us any at all. No amount of fancy equipment will help. There are a couple of organisms that we refer to as high priority bacteria. And I'm going back to the bacteria because in the hospital setting, those tend to be the ones that affect us the most. And I want to mention here, because these are some terms that we'll see some from time to time, fluoroquinolone resistant E. coli, vancomycin resistant Enterococcus species, and there are different ones. We have third generation cephalosporin resistant E. coli and Klebsiella pneumoniae. We have carbapenem-resistant Klebsiella pneumoniae, carbapenem-resistant Pseudomonas aeruginosa, and we know that our carbapenems are generally reserved for those harder to treat infections. So imagine when not even the carbapenems can work. Then there's MRSA, which we talk about all the time, and that one is methicillin-resistant Staphylococcus aureus. And we have things like penicillin-resistant Streptococcus pneumoniae. This one is emerging. Never used to be a big problem, but more and more we're seeing it around the globe. Now you have select countries like those who are part of the Organization for Economic Cooperation and Development, which is made up of 35 different member states. And they noted that there was an increase in their AMR levels, in their antimicrobial resistance levels, from just 14% in 2005 to as high as 17% in 2015. And there's a projected increase, not that it's going to 18, it's projected to increase by another 18% by 2030 if we continue on our current trends. And just to give you an idea of what this would look like on a country basis, look at some of these countries that make up these OECD countries. Countries like Ireland, look at Greece, look at the United States. So the little circle, let me see, I hope you can see my pointer. The little circles here, the two-toned circles, represent what the resistance levels look like in 2005. And we see for some countries, it was pretty low in 2005. And then by the end of 2014, look at the rates. So it's a problem not just for poor countries, but some of our richer countries, more developed countries too, have serious issues going on. So what do you think is happening in our little country? Maybe a big problem, but if we're not looking for it, then we don't know. So this is something that we need to work on. If we were to look at our neighbor, I think you can call them our neighbor, just a little bit north of us, the United States alone estimated that there's over 2 million infections or illnesses caused by multi-drug resistant organisms each year. And that usually results in about 23,000 persons dying from these very hard to treat infections. And that's just in the US. Globally, it has been reported that over 214,000 newborns actually die from sepsis with a multi-drug resistant organism, usually bacteria. So these, of course, it makes your ears perk up. 214,000 newborns, that's a lot. It has implications on a national level because now countries have problems with or they're not able to appropriately address poverty, inequality, the welfare of their animals, the condition of their environment, food safety and security, because monies now have to be diverted to help to take care of this situation, to help the health sector to deal with the situation. The World Bank approximated that about 28 million people could be pushed towards poverty by 2050, with the overall cost to the global economy of about $1 trillion per year just to deal with antimicrobial resistance. So we can't see it in a vacuum because antimicrobial resistance must be seen as a development problem. Countries can't improve, can't do better if they're stuck in this rut of dealing with antimicrobial resistance. Again, globally, it's estimated that by 2050, there'll be about 10 million deaths associated with multi-drug resistant organisms or antimicrobial resistance in general. And this could cost upwards of 66 trillion pounds. Now, Jamaicans know very well that the pound is stronger than the US dollar. So we're not even talking US dollars here. We're talking 66 trillion pounds. That's what it can cost to look after this global problem. So what happens when this becomes an issue in our hospitals, in our country, or globally? We know that it spread a lot, especially in countries that don't have much control over how prescriptions are used, about how drugs can be sold for human use or animal use. In some countries, antibiotics are sold across the counter, just like you'd pick up some Panadol. You can pick up some antibiotics. So any country that doesn't have standard treatment guidelines and policies in place to help to prevent this, you can end up now leading to ineffective first-line agents, because these first-line agents are likely the ones to be sold over the counter, and so these won't be working. The patients who get these infections will end up having to stay longer in the hospital, higher medical costs, healthcare costs. The drugs that are going to now have to be sourced to treat them are likely going to be much more expensive. So that's added cost to the patient, added cost to the institution. Of course, there's increased mortality, and that's a major issue. And in general, there's going to be a higher economic burden on the family and society. So if we don't put in some urgent action now, we may enter what we call the post-antibiotic era. And in that era, we're basically going back to the 1920s, where common infections and even a minor injury could actually lead to a patient's death. And that's a serious thing to think about. We know some of the causes, we've mentioned them before, but just to highlight: the overprescription of antibiotics or the inappropriate use of antibiotics. Why should I have a viral infection and be taking antibiotics? A sore throat and the doctor told you it's a virus and you go and you still push to get the antibiotics. This becomes a problem. Poor infection control in your hospitals and in the clinics. Not doing the appropriate steps to maintain sterility in equipment, or to use PPE to help to prevent spread, hand hygiene, things like that can help to allow for the spread of antibiotic resistance. Patients not finishing their treatment, patients sharing their treatments or the drugs that were left over with others. All these things, not taking the drug for the appropriate duration of time, can help to foster antimicrobial resistance. Lack of hygiene and poor sanitation, of course, we know that must be a major issue that will help to push antimicrobial resistance. Overuse of antibiotics in livestock and fish farming. A lot of persons mentioned yesterday in our Agri-Food Day that they weren't even aware that animals and fish got antibiotics. They do. And if it's overused and inappropriately used, and then we consume these animals, because these are all food animals we're talking about here, then we can get these bugs that are already resistant in our system. We can get ourselves exposed to antibiotics that we did not even take ourselves, and then teach our own gut flora, our own commensal organisms how to become resistant to these drugs. So therein lies the problem. And then another big problem is the fact that the drug companies have decided it is not fiscally feasible. It's not sustainable for us to keep making antibiotics because these bugs are too smart and they learn how to be resistant in no time. So it's better for them to make anti-diabetic agents, antihypertensive agents, because they can make money off of this, right? But to keep making antibiotics seems like a waste for them, so they don't do it. And this is a problem. Environmental pollution is another thing I would add to this. And basically, we mentioned before that sometimes they just don't want to make anything new because it's not worth their time. If we look at what has happened over time, I think this is a very nice little graph here, or graphic, that shows you that in the 80s, the production of new antibiotics was booming because it was big money business. But by 2012, the number of new agents being produced has absolutely declined because it's just not worth it, or the companies believe it's not worth it. So how do we know, after we've received these antibiotic resistant organisms within our own cells, how do we spread it? So we know that a patient who already has an antibiotic resistant organism in their gut, on their skin, in their wound, anywhere on their body, may now attend a clinic or hospital. And these multi-drug resistant organisms can spread through poor hygiene within that facility. Know that once it spreads in the facility, it can become a part, what we call become endemic to that institution. So it can be found on the faucets, it can be found on the tables, etc. It's now a part of that hospital. When that happens and a new patient comes in, then of course you can always spread it to the next patient because of poor hygiene. Antibiotics that are given to animals are used on crops as well. We mentioned before that these food animals, once they have these multi-drug resistant organisms, or they're full of these antibiotics, and then we consume it, then we know can end up with these organisms as a part of our commensal makeup, and then share it if you want to call it that, with others. So that's generally how it tends to spread. Now, there have been several commissions, several groups that have been working on different ways to tackle this problem. And of course, you'll hear the term the One Health approach being used over and over again. And I found this nice little list with what would be all the steps that need to be undertaken to help to tackle the problem. So we know it's a global issue, so therefore we need a global public health campaign. And the World Antimicrobial Awareness Week is one such campaign that has been put on by the WHO. We know that we need to push for the improvement in sanitation, improvement in awareness of how to prevent the spread of the organisms. We need to reduce the unnecessary use of antimicrobials in the human sector, the agricultural sector, and in the environment. We need to improve global surveillance for drug resistance. If we don't look, we don't know. And then we need to promote the development of new rapid diagnostics. So we may want to know, but if we do not have laboratories that are equipped to help us to identify these multi-drug resistant organisms, then we will not know. So we need to work from the front backwards and then from the back forwards again. Improve the lab, do our surveillance. When we know what we're working with, then we can actually attack the problem a little bit better. We need to promote the development and use of vaccines and other alternative agents to help to limit the spread of the organisms throughout populations as well. We need to improve the number of and recognition of people who are working in the field, because some persons don't even know what an infectious diseases doctor does, or what a microbiologist does, or what an infection prevention and control specialist does. If they're introduced to them, if we have more of them available, and we can spread it in all of our institutions, spread these persons and their expertise in all these institutions, then it will help curb the spread of antimicrobial resistance. We need funding. Absolutely, we need funding. Better incentives to promote investment in new drug development. And we need to build global coalitions for action. So just to reiterate some of the things that's being done by major groups, we know the One Health approach will include different sectors from human health, animal health, agriculture, etc. And we have groups such as the United Nations and all their agencies that work under their umbrella, and other international groups as well who work together like the FAO, WHO, OIE, the World Bank, and they've been helping with the development of strategic plans and national action plans to help to address AMR at the country level. In fact, WHO did a survey in 2018 which noted that 117 countries had developed their AMR national action plans, but only a fifth of these countries had the funding to implement the plans. So we're noting here that whilst we are trying to do the groundwork, funding is an important issue that needs to be addressed. The WHO has also put in place different strategies that they've shared with the globe, shared with different countries, and they've developed several different awareness campaigns, surveillance methods, and research to help to strengthen the country's capacity to actually look into the problem. They've developed different policies and protocols that they've shared globally to help to reduce the incidence of infections and to optimize the use of antimicrobials, etc. We mentioned that we are here today because of such an initiative that was started in 2015, and it's being held annually between the 18th to the 24th of November each year. And the slogan is actually now Antimicrobials Handled with Care. There are other programs that were put out by the WHO, including the Global Antimicrobial Resistance Surveillance System, the Global Antibiotic Research and Development Partnership Group, the Interagency Coordination Group on Antimicrobial Resistance, and all these groups have been working together with the goal, or I should say they have set goals for themselves for, by a particular time, we should have X factor in place, we should have established X, we should have been doing X. And if we work with goals and we have a vision, then I think we can achieve quite a lot. The CDC has also developed programs. They've shared their expertise with different countries. They've helped to implement a lot of these national action plans and infection prevention and control programs globally as well. So we see that there are several organizations that have been working around the clock, because it can't be just during World Antimicrobial Awareness Week that we're attacking the problem. It has to be a year-long, everyday issue, everyday thing that we push to ensure that we actually have antimicrobials in our back pocket to treat any infection that may arise, and we can decrease morbidity and mortality. And then, of course, there are the little things that we can do on the individual level. Only use antibiotics when they were prescribed to you by a certified health professional. Always take all of your antibiotics that you are prescribed, even if you start to feel better, right? Never use leftover antibiotics, not your own or not somebody else's. So never share antibiotics with somebody else. And to help to prevent infections from setting in place, regularly wash your hands, avoid contact with sick people, keep your vaccinations up to date, and keep your health up to date. For persons who are diabetic, etc., if you maintain good health, maintain, keep all your checks, your doctor's visits, etc., this will help to limit the amount of infections anybody who may be immunocompromised may have, and limit the advent or the start of a multi-drug resistant infection in that individual. So with that being said, I hope you've been appropriately introduced to this topic for today. So we see that it's a global problem. We see that it's very important for us to actually attack this problem. And we see that we need to attack this problem from several fronts. So with that, I hand back over to our moderator for today. Thank you for listening.
Thank you so much, Dr. Reynolds Campbell, for an excellent talk. It was comprehensive, it was engaging, it was informative. Our next speaker is Dr. Karen Shaw, who will be presenting on the basic principles and practices of infection prevention and control. Dr. Karen Shaw is a consultant clinical microbiologist who currently serves the Ministry of Health and Wellness as Director for Health Systems, Support and Monitoring since May 2021. She has also served as the Director for Technical Support between 2018 and 2021. Dr. Shaw has been integral in the fight against COVID-19 in Jamaica, serving tirelessly since the first case was identified on our shores. Dr. Shaw, over to you. We look forward to hearing from you.
Good morning, everyone. I'm not sure if you seeing my screen?
Yes, we can see your screen.
All right, great. So morning, everyone. The discussion is about the basic infection prevention and control practices. I mean, we understand the challenge that is ahead of us. And I think Dr. Reynolds Campbell has put forward, what the problem. So with the increasing burden of AMR, we have to look at some of the solutions. And the infection prevention and control is one of those tried and true solutions. Okay, it's not moving. Give me 1 minute. Try this again. There we go. So we remind everyone of, how we get to the concept of infection prevention and control. We know it is a scientific approach. And what it's going to do is provide practical solutions. So the persons that are working in any of the health settings, we're looking at providing them with working solutions that are applicable and sustainable. And the reason why we invest in infection prevention and control is because we understand that we are trying to protect our patients, our clients, and we're also trying to protect our assets, which are really our healthcare workers. It's grounded on many different principles. We have infectious disease, epidemiology, etc. And what it is that most persons need to understand that it isn't someone else's responsibility. It is actually your responsibility as a healthcare worker or a healthcare provider. And therefore, you have an important role to play in this discussion. So how do we know that infection prevention and control is effective? The evidence exists. I'm just going to show a few, if you want to say, success stories. And we look, wherever there is an introduction of an effective infection prevention and control program, you can see actively the 30% reduction in what is called healthcare associated infections, HAI. This is a new name. It would have been equated to what we used to call the nosocomial infections. But they've broadened the term because we recognize that we deliver healthcare in a number of facilities, and they've expanded the spectrum. So you think about your hospitals, your primary care setting, your long-term care. So you have your, you have your rehabilitative, your nursing home. So anywhere it may be that you're offering healthcare, once you have an effective IPC program, you can reduce the presence of healthcare associated infections. Of course, surveillance is a critical aspect of infection prevention and control. We have to monitor and be able to talk about our trends. And once you start your surveillance, you can also see a significant reduction in these healthcare associated infections. Looking at one of the practices under IPC, which is hand hygiene, which we will talk about a little bit later, we see that improving hand hygiene practices, showing the healthcare workers within the system how to do the process properly, when to do it, helps to reduce the pathogen transmission in healthcare settings by at least 50%. And wherever there, as I said, there are strong plans, once you see the introduction of these plans, no matter which country it is, you can look at some of those targeted organisms, which I think Dr. Reynolds had put in her list, and you will see decreases in these items. So what we want is to understand that IPC has benefit, and it is tangible benefit. Now, what's the relationship with antimicrobial resistance? I mean, we've gotten a definition of it before, just to go over. It's just when you recognize that, whatever organism that it is, whether it be bacteria, viruses, fungi, or parasites, whatever you normally use to treat these microbes, you'll find that it no longer is responsive. And therefore, we may have to add new medications. We may have to, combine medications, and therefore it can be costly. And we know that AMR is a global crisis. I think that is pretty much the take-home message. But the light comes through the discussions of strong IPC being the most effective approach to controlling the spread. If it is that you've identified an organism as being resistant, it doesn't mean that you have to have it, propagating through your facilities. And these are some of the practices that we are going to look at, in order for us to stem the tide. So we know that with standard precautions for infection prevention and control, and what's under it, the aspects, the practices that we're going to be looking at, you have your hand hygiene. We talk about the use of the personal protective equipment, how you use and dispose of sharps, the process of, cleaning and disinfecting and reprocessing medical equipment is a part of it. Routine environmental cleaning, respiratory hygiene and cough etiquette. We talk about the aseptic approach, effective waste management, and you look at the approach to handling linen, and last but not least, vaccination. So we need persons to understand that the vaccination is a strong proponent under the IPC. So all these things, fit together for the benefit, and it is how we are going to control AMR. So what does IPC, if you take all of those moving parts, remember there's no one element that can conquer the situation. And even with IPC, we still have to depend, or it's sort of like if you think about a lattice work, or maybe even a spider web, there are other elements that we want to attack the situation of resistance. So in the health setting, we're looking at doing our IPC practices, implementing some of our safe water sanitation and hygiene services. So when you put these things together with some of our practices, what you'll find, the overall thing is that we will get to reduce the resistant microbes. So you're looking at other elements such as your antimicrobial stewardship, and we'll be talking about that on Tuesday. So we are inviting all of the persons on this call to join us then to have a look at that. So let's take it from the beginning. We talk about standard precautions, and as the name says, it's just the basic level of IPC, and it is to be used. You see there, the red is really your take-home messages. All patients at all times. So it is not a suggestive. It is not you are not doing it for some. Yes, the patient may look fairly well. What we expect is that you're doing your standard precautions for all patients at all times, whether you know what they are suspected of or confirm status of the patient. And what is the goal of taking this approach? Well, really, you are going to be limiting or preventing contact with secretions. And these secretions can be body fluids, can be skin lesions, it can be the mucous membranes, and you think about blood and body fluids. So if you take standard precautions as the baseline, you're going to minimize a lot of these events, and therefore you decrease the opportunities for exposure and infection. And it is based on what we call a risk assessment. And therefore, you're going to apply this risk assessment in all critical activities. Now, it can be an active assessment where you sit and think out and plan out. And I don't know if a lot of you would recall the discussions of Ebola. We used to have to explain to persons that you're not going to be seeing a patient of that magnitude and you just go. You should plan your activities. What are you going to be doing for the patient? And therefore, what kind of items do you need? What kind of precautions do you need? But it can be an active event, this risk assessment, as well as it can be a passive risk assessment, which means that it's second nature. So some of the elements of standard precautions, just want to highlight these. You have hand hygiene being it's almost like the foundation. So the first three are foundations, which means that they anchor the other, 4 or 5 elements. So hand hygiene is for between every patient. It is done all the time. PPE, according to risk. And then, of course, you have environmental cleaning. And then you have 4 through 8. These are sort of event-based precautions. So for example, if a person, has to sneeze or cough, we talk about respiratory hygiene or cough etiquette. If it is that you have to deliver an injection, and we are in that process at this time, we talk about the safe injection practices, sharps management, and injury prevention. If it is that you have the opportunity, the safe handling and cleaning and disinfection of patient care equipment. So you take them to surgery, or you go ahead and you just do some minor procedures. We want to be able to handle these items efficiently. Under it also, you have the safe handling of cleaning of soil linen, and last but not least, waste management. So the first 3, as I said, they are foundations. They must happen. And then you have event-based, incidents, and therefore we must know how to manage. So let's look at hand hygiene. This profession is one where, we can safely say we work with our hands. Our hands are our main tools for work. And therefore we have to appreciate the link between our hands and transmission of microorganisms or the spread of germs in the healthcare setting. So if you think about you handling, for example, your equipment, going straight to touching the door, to leave maybe even your private office, handling medications, to holding hands with your loved one, answering your personal cell phone, and then tending to patient. Just think about the distance that our hands have traveled. And therefore, you have to appreciate that in making sure these elements are clean, a lot of times we don't do it effectively. So there are parts of the hands that tend to be missed in cleaning, and it is important that we learn the appropriate technique to address these issues. And we want to point out that wearing gloves does not remove the need to perform hand hygiene. So even though you may wear gloves for the activity, you need to appreciate that you still need to wash your hands. So what WHO has done is sort of made it a little easier. They've identified at least 5 moments. They're not the only moments, there are 5 moments, especially in the clinical setting. So we have 2 that are before normally and 3 that are after. So before you go to touch any patient, you definitely want to perform hand hygiene. And you have choices. You have your soap and water method and you have your alcohol method. And we should be very, very, very proficient in this now, especially in the time of COVID. You are going to also ensure that you are cleaning your hands before you do an aseptic procedure. So you're going to take blood, you may be going ahead and putting in a tube. The point is, once you're going to be doing any of these types of procedures, hand hygiene is a given. After, we talk about handling anything that is with body fluids from the patients or after touching the patient. And of course, don't forget that touching around the patient, so the patient's environments, are 3 opportunities after that we should be looking to wash our hands. As I said, in this time, we should be exceedingly proficient. So the technique, so we talk about the 5 moments, and now we're looking at the actual technique. And it is the same. It doesn't matter what agent you're using. The approach, how you go about doing the washing is the same. So they've managed to standardize it. And therefore, what this will do, you will see portions where you rub the palms together. You talk about the interlocking of the fingers, right and left. So you get between the webs. We make sure that we are rubbing our thumbs and scrubbing our palms. These are essential steps to help to decrease those areas that may be missed. How long are you doing it for? Well, you're rubbing your hands for about 20 to 30 minutes. And this is with the alcohol-based hand sanitizer, usually around 70%, can anywhere between 60 to 70%, but 70 is usually recommended for the health setting. Soap and water, and you're washing your hands for about 40 to 60 seconds. So the next topic is really about personal protective equipment. We use it short as PPE. It is specialized clothing, because we get asked that question very often. What do you mean by PPE? It's specialized clothing. We've been doing it from, time immemorial. This equipment is usually worn by the healthcare worker for protection from infectious or harmful materials. So that's the definition. And it can include gloves, which usually protect the hands, gown or apron that protect the skin. You have the mask or the respirators that protect the airway, so the mouth and nose. You have your goggles or your face shields, which protect the eyes, and the face shield, which it extends all the way down. So it's not only doing just eyes, but it is protecting the face in general. And what we continue to remind persons in terms of the hierarchy of controls, PPE is a given. You must utilize it, but you need to understand in terms of where it fits as a infection prevention and control strategy, is that it is it's usually considered to be the least effective. And the reason why it is the least effective, you're thinking about the sole protection of the wearer. It is not something that will help to protect the masses. So therefore, you have to utilize other methods in conjunction with wearing your PPE. And this is one of the reasons why we are showing this slide. So in order for you to choose the PPE effectively, you need to do a risk assessment. And the risk assessment is looking at exposure and the extent of contact anticipated with blood, body fluids, respiratory droplets, or open skin. So you say, okay, if there is a risk of these things, what do I need to wear? That's really what the risk assessment is saying. So you select the PPE based on what it is you think is the true risk. You're going to perform your hand hygiene. We've already talked about the 5 moments. And of course, you need to understand that it is to be done for each patient. each time. So it becomes routine. And this is why I said it can be either passive or active. Some persons get so familiar with the concept that you know exactly what you're going to reach for. And then for some, it has to be a conscious thought where you're going to say, what am I really going to be exposed to here? So let's go through it, to sort of see the eyeballing of the technique, the risk assessment. So here's a scenario, always before and after patient contact and after contact with a environment. So this would represent almost your day-to-day. You're going to say hi to the patients, that sort of thing, or you may be seeing the patients in your office. You're touching the surfaces, and you definitely need to have hand hygiene on board. And as I said to you, that is a foundation. If direct contact with blood or body fluids, secretions, excretions, the mucous membranes, or non-intact skin, what you're going to be looking towards now is hand hygiene and gloves. If there's a risk of splash to the body, so you're going to be taking or changing some sort of tube, and it may be a blood vessel, whatever it may be, you realize that if there's a splash, then you need to add a gown to what you have as your foundation, your hand hygiene and your gloves. And if there's a risk of splash to the body and the face, then now you're going to add 2 more, which is the discussion of the medical mask, the face shield or the eyewear, the goggles, plus the other things, the gown, glove, hand hygiene. Now, so this is the risk assessment we take to all patients. And then you need to also appreciate that there may be personal protective equipment for specific precautions. Sometimes there will be diseases that, they have a specific method of transmission, and therefore you need to, it's not that you throw out your risk assessment. The risk assessment has been done for us, and therefore it is more a compliance or an application of what is a recommendation in terms of the PPE to be used. So for example, we make it easy when we talk about contact precautions. You have your gloves and your gown. You have the droplet precautions. So you're adding, your medical mask. So this is a discussion that would be very applicable in the time of COVID. You have your airborne or your aerosol precautions, and this is where you're adding the element of the particulate respirator. So these are really based, as I said, on the infectious agent. We know about the element already, and we know specifically that they are passed from one person to another through specific methods of transmission. So you have contact, droplet, and airborne, and therefore we choose, there's already been decided for us what our PPE needs to be, and all we're saying is you're going to apply it. Some principles, once you get into the discussion of the PPE, so we've chosen wisely, we're now getting ready to done. We just want to know how to guide ourselves. Understand that you need to clean your hands, definitely, before and after. So after you take off the PPE, definitely first thing you want to do is your hand hygiene. The PPE must be available and in the correct size. So, you're going to need some selection. Always put on before you get in contact with the patient. So, we have a theory that the patient may be coding, may need, a series of intervention now, and therefore we cannot put on the PPE before engaging them. That is not necessarily true. You have to ensure that you put on your PPE in order to deliver, the safe care to this patient. So it doesn't make sense to expose yourself unnecessarily. What you want to do is ensure that you're proficient, that you can put on your PPE with, time being a factor safely and address the patient's needs. So always remove immediately after completing the task. Yes, I can't say that, that item needs to be strongly enforced, because sometimes we forget, we may have on the gloves for extended periods. We may have on other elements, the gown or such, after caring for the patient, and we don't remove it right away. Never reuse disposable PPE. Okay, well, with COVID, this now has become quite a debate. And of course, there are recommendations about, reuse of some, not all. So the general rule of thumb is that we are never to reuse disposable PPE. And then of course, for those that are reusable, so if you think about some of your face shields and stuff, what you need to ensure is that you clean and disinfect them. You're going to change your PPE after it becomes contaminated and or damaged. You're not supposed to, once you're in the getup, you're not to be adjusting or touching during patient care. So sometimes, you know, the tendency, we even in our day-to-day, we may have on the mask, we've been actively engaging persons, and the tendency to be pulling the mask up and down while you talk, you know, is one of those no-nos. So you're never to touch your face while you're wearing it. If there's a concern, if you think there's a breach, you are to gown down and go to your place of safety, remove all the PPE and re-gown. Always remove carefully, right? That's the next thing. You're moving from the dirtiest to the cleanest. So you have to, as I said, this is a procedure that, you know, you're not going to rush through. You need to become proficient in so you avoid self-contamination. So in terms of environmental cleaning and disinfection, you know, it is important to ensure that we are doing this on a consistent and correct basis. It's very important to know that if we thoroughly clean, you know, all our surfaces, even with the simplest agents. So sometimes persons believe that we need, you know, high level, you know, or expensive disinfectants, but truth be told, even just simple soap and water can be effective and sufficient in terms of controlling even, you know, bugs that may be resistant. So you need to approach the discussions of cleaning and disinfection. The important thing is, how often should you do it? Well, it is very simple to understand. You have to think about your surface and what is it doing? So if we divide surfaces usually into high touch and low touch. And examples, for example, if you have a door, going in and out of the door, that's something that you touch very often. Your stethoscope is something that you touch very often. So therefore, it needs a lot of cleaning, needs to be cleaned frequently. Compared to your windowsill, I mean, more times than not, we hardly touch our windowsill. So the type of activity that's taking place in the area, the risks that are associated. So is this a hospital setting versus your office? Then you realize the level of cleaning has to be different. If this is a hospital ward, the expectation is going to be higher level of cleaning expected. Vulnerability of patients. So what type of patient, if we're in a clinical setting, what type of patient are we housing here? Is it someone critically ill with a lot of tubes, many opportunities to put, you know, these sort of microorganisms in and out of the environment? Therefore, versus someone may have, you know, you see the patient is ambulating, and therefore they're transient in their passage through your facility. The probability of being contaminated, very important. Is this a washroom where, you know, the activities in the washroom, you think about some of your dirty facilities, your sluice, what is the purpose of the area versus, you know, you think about an area where there's minimal engagement. So for example, a staff lounge or even the canteen, people are just sitting and eating. So you have to look at the probability of contamination. And then of course you add in the presence of the resistant organisms. Are they there or not? And then you will know definitely if you have antibiotic resistant organisms, then you expect that you scale up your cleaning frequency. I apologize for the quality of the slide, but just to note, you know, the take home, high touch areas, very simple. I've said it in many forums. If it is a high touch area, then it must be cleaned frequently. It's no mystery. And therefore low touch areas are cleaned routinely. So quick eyeball, you know, for persons in terms of the medical setting, if we just took a picture of a common, you know, ward setting, the red dots represent the things that are high touch. So you see there are a number of items, even at first blush, that need to be cleaned very often. Respiratory hygiene or etiquette, what we used to call cough etiquette. So it's an opportunity to reduce the spread of microorganisms that cause respiratory infections. And this can be anything, cold flu, it would involve COVID at this time. And what we're asking persons is that if you feel the need to sneeze, you turn your head away from others, you sneeze in your sleeve, your elbow, you cover, make sure if you're utilizing a tissue, disposable item, you cover the nose and mouth. And of course, we want that tissue to be discarded immediately after you have utilized. And, you are going to be, as I said, there's your foundation of cleaning your hands with soap and water or alcohol-based products. So safe injection, well, it's important to know that if you are, undertaking injections, it can be a vehicle for transmission of infection. And the most, some of the more common ones, hepatitis B, usually about up to 30%, hepatitis C, which is about 3%. And then of course, HIV, most persons, tend to hang the hat on HIV, but we recognize that hepatitis B is easier to transmit hepatitis B through these sorts of through injections. So when does the staff become exposed? Well, if you are giving unnecessary injections, so we have also opportunities for when we're recapping, and I think everyone on the call should know that in health, and it varies because there are a number of dynamic specialties in health. So for human health, recapping is a no-no. In a dental setting, recapping occurs, and therefore, when we talk about it, this statement here is for human health, and I would like those persons to appreciate. So recapping is not recommended. And for our other counterparts, there is a procedure on how to do that where you can safely recap because their delivery mechanism is different. The improper handling of sharps. We've seen this many, many times. And therefore, one of the main, factors leading to this, it has to do with the distance of the disposal system being from the point of generation. And of course, you have poor positioning of the patient. So just a few tips to help improve, the injections. We talk about clean workspace, hand hygiene. There it is again. It's in every slide so far. Looking at your delivery mechanism, making sure that wherever you're taking the solution from, medication or diluent, you clean it. You talk about cleaning the skin prior to delivery. And of course, moving or having access to your sharps container closer to the point where you're going to be delivering this shot, and therefore we have appropriate waste management. So just to remind, we talk about leaving needles behind, sticking the needles everywhere. Those are usually the opportunities. So we want to minimize as much as possible those opportunities. So those are the practices that are under standard precautions. I would just like to reiterate that, the infection prevention and control, it is as I said, it's born from science, but the fact is that it has workable, solutions. And we do it because we want to protect everyone. So that is that's the basis, that's the payout. Standard precautions that we have discussed here now, they're work practices, and they are required to achieve what we are looking at as a basic level of infection control, and they are recommended for the treatment and care of all patients. So we are not making, the risk assessment is not whether or not the patient you need to apply IPC for the patient. It is that we are applying IPC for all patients, at least standard precautions, which is our basic level, and then we are adding to it. We know that, we are in the midst of a global crisis regarding antimicrobial resistance, and therefore one of our assets is going to be the infection prevention and control arm of things, the approach, and therefore it is one of the effective methods of controlling the spread of antimicrobial resistance, especially in a healthcare setting. So I thank you. I will just leave you with these thoughts that you are to do your part and practice good IPC from the start. I thank you. I turn it back over to you, Madam Chair.
Thank you, Dr. Shaw, for another excellent presentation. I just want to remind our participants that you can post your questions in the chat. We will have an opportunity for question and answer at the end and for further discussion. At this time, Dr. Stempliuk from PAHO WHO has already been introduced, will return to us one more time for a second talk. She will be talking to us about breaking the chain of infection. Dr. Stempliuk, the floor is yours. While we wait for Dr. Stempliuk's second presentation, I just want to let you know as well that you need to ensure that you register for this seminar, particularly if you are interested in getting CME credits.
Dr. Stempliuk is currently having some internet issues. Would you like to go ahead, Dr. Goff? Okay.
Sure. Okay. All right. So while we wait to have that sorted, we will then move to our next presenter, who is Dr. Rhea Goff. Dr. Rhea Goff is a consultant medical microbiologist, having earned her MBBS and DM degree in medical microbiology from the University of the West Indies. There, she also earned an MPH degree. She has provided expert consultations at the National Public Health Lab and at the Ministry of Health and Wellness, Jamaica. She has delivered several talks and is a member of the specialty board at the University of the West Indies and makes special contributions to the training of young doctors in the field. We're happy to have you, Dr. Goff. Welcome. We look forward to your presentation. While Dr. Goff loads her slides, I just want to make a slight correction. You will get a certificate of participation, not CMEs, once registered. My apologies. Dr. Goff?
Yes, good morning. So sorry, are you hearing me?
Yes, we are hearing you clearly and we are seeing
I'm not sure if you were hearing me before.
No, we were not. We were not.
Oh, I'm so sorry, but I was just thanking you for the introduction and stating that I appreciate the opportunity to present to you all today. So let me go ahead with the presentation. Not sure why it's not going to full screen. Let me see. Are you seeing it?
Oh no, we're no longer seeing it.
No. I may have to present from
Okay, that's okay.
Yes. Are we okay now? Are we seeing it clearly?
Perfect. Thank you.
All right. So The topic for me is the impact of COVID-19 on antimicrobial resistance. First, I will go through just a couple introductory slides to kind of bring things into perspective before hitting the main topic. So when we speak of COVID-19, it's a SARS-CoV-2 virus we're referring to that was named on February 11, 2020 by the International Committee on Taxonomy of Viruses. And COVID-19 is the name of the illness caused by SARS-CoV-2. Transmission, usually by respiratory droplets or contact, and in some cases airborne. Symptoms, we know, may occur within 2 to 14 days of exposure. And these may include fever and chills, cough, shortness of breath, myalgia, fatigue, as well as maybe just mild, maybe loss of taste, smell. We know that 80% or most infections are not severe and patients recuperate without any special treatment. However, you do have a proportion of persons who may require hospitalization and also may require ICU care. So clinicians usually have differential diagnoses in mind, must always be kept in mind that their symptoms could be due to other viral infections, bacterial infections, and these patients may have, in addition to co-infections, super infections on top of their viral illness. So a little intro on antimicrobial resistance can be defined as the ability of a microorganism to resist the effects of an antimicrobial agent to which these organisms would be previously susceptible. And when we speak of antimicrobial resistance, it would not necessarily just be to antibiotics, but antivirals, antifungals, and other agents used for other microorganisms. So the World Health Organization has described antimicrobial resistance as a global health and development threat. It has declared it as one of the top 10 global public health threats facing humanity. We know that the economic cost of it is significant, and it threatens our ability to treat common infections, as stated by Dr. Reynolds Campbell in her presentation previously. This slide really is showing the whole cycle of these resistant bacteria, going from humans, in which you may have the inadequate use of antibiotics, gets into the environment, bad wastewater, then you have use of these agents in animals, gets into manure, which is used for agricultural purposes, and you have the whole cycle getting it back into the food chain and back to us as humans, and not to exclude the hospital setting where these organisms tend to thrive, and particularly if they are not practicing the correct IPC measures. So how antimicrobial resistance develops, in order for bacteria, and I speak mainly of bacteria for this presentation, but how they develop this resistance is that they disrupt a step in the action of the antimicrobial agent. And there is no single mechanism that can explain why bacteria become resistant to a particular antibiotic. But several different mechanisms may come into play to confer resistance to a single agent, as well as multiple mechanisms may come into play and result in resistance to multiple antimicrobials. So this slide, which you would have seen previously in Dr. Reynolds Campbell's presentation, but very useful one to show the causes of antibiotic resistance, overprescribing of antibiotics, which is a major driver of this. Patients who receive treatment, not completing course of therapy, overuse in the agricultural sector, poor infection control in the hospitals, lack of hygiene and poor sanitation generally within the community, and of course, lack of new antibiotics being developed. And then in terms of spread, which I would have discussed from the previous flyer that I looked at, the whole cycle through the animal environment, food chain, hospital setting to us and then back to the community setting from patients who would have been admitted and exposed. So just to note that antimicrobial resistance can be intrinsic or extrinsic or acquired. So intrinsic would be organisms that may have an innate ability to resist the activity of a particular antimicrobial agent through its inherent structural or functional characteristics, which will allow tolerance to the particular drug or class of drugs. And acquired resistance would include the ability of an organism that would have been previously susceptible to now acquire this resistance, which can either occur by mutation, which is changes directly in the genes for that particular organism, or you can have horizontal gene transfer from one organism to the next. So these antibiotics, when what they do is exert selective pressure on bacterial populations, so they resulting in killing of the susceptible bacteria and allowing more resistant strains to survive and multiply. And it's these strains now that transfer these genes to other strains of similar bacteria or even other bacteria, other groups of bacteria. So, right. And this just goes into a little more, which I won't spend much time on, just to say that, and the bacteria have different ways to acquire these resistance genes. They can transfer directly by contact with each other. They can pick up these genes from the environment. They can acquire the genes through what we call bacteriophages. So there are many different ways they acquire them. So mechanisms of antimicrobial resistance. So it may involve modification of the target site for the antibiotic. The bacteria may produce enzymes that hydrolyze the antibiotics and prevent their action. They may block the entrance through the cell membranes, or they may have pumps that push the antibiotics from their cells. And this is just showing some of these occurring. So patients with COVID-19 can experience infectious complications of this viral infection, and some risk factors for these would be presence of comorbidities such as diabetes mellitus. You have another risk factor would be in immunocompromised patients, but also use of immunomodulators to treat COVID-19 can also put people at risk for these. So these infectious complications, so you can have co-infections that the patients may present with, or they may get infection during the course of illness. So co-infections could include concomitant viral infections or community-acquired bacterial pneumonia. They may have reactivation of latent infections, hepatitis B, herpes simplex, and strongyloidiasis. And patients can also get nosocomial infections, in that those that are hospitalized may develop hospital-acquired pneumonia and others. So, and you can also have the risk of opportunistic fungal infections, once again, for those hospitalized patients who may be ventilated, immunocompromised, so on. So, first, impact of antimicrobial resistance on COVID-19 clinical care. So patients presenting, oftentimes they may present with a pneumonia type picture, and so leave the clinician with a decision whether to give antibiotics or not. And so you find that a lot of patients may receive empiric antibiotics, and where there are challenges with diagnostics and differentiating between viral and bacterial infections, you find these people may also get empiric antibiotics. And as stated before, patients may have secondary infection requiring antimicrobial therapy. And also, depending on local antimicrobial susceptibility data, we're in areas where you may have high resistance, patients may be given more what you would call powerful antibiotics that may have less favorable safety profiles, or they may get antibiotics in areas where there's low resistance antibiotics that may not be very effective. And so these things can affect patient outcome. So the impact of COVID-19 on antimicrobial resistance. To note, the evolution of AMR has 3 components, basically, all of which can be affected by COVID-19. And this information, was a useful perspective found from a very interesting article by Knight et al. So, I bring the perspective to you today. So, so the 3 components: emergence, transmission, population level infection burden. So the emergence is driven, as stated before, by selective pressures on antimicrobial populations in humans, animals, or the environment. And this facilitates the acquisition of the resistance mechanisms. Then you have transmission, influenced by environmental conditions and behaviors. And then you look at the population level infection burden. So the burden of illness caused by resistant organisms is dependent on the number and nature of infections and the availability, effectiveness, and safety of alternative treatments. So COVID-19 pandemic resulted in governments having to implement measures to combat this infection and prevent spread. And measures utilized included domestic and international travel restrictions, school, workplace, and non-essential service closures, physical distancing, mask wearing, and consequences of these measures included supply chain disruption, healthcare access disruption. There were financial impacts in many countries, and the matter of rising inequalities. So this slide appears a little crowded, but it's just to show how all these factors, the factors that play a role with these 3 components: changes in antimicrobial use, which is further impacted by antimicrobial availability, financial hardship, infection prevention, affected by the infection burden in healthcare settings, the hygiene in the community, physical distancing measures, and changes in the health system, which would involve clinical care disruptions, changes in health-seeking behavior of the population, and vaccination. So starting with changes in antimicrobial use, antimicrobial use in those with COVID-19. So as stated before, a significant number of these patients would receive antimicrobials. And as a result, there's a risk of development of resistance. Some patients would have experienced post-COVID-19 structural lung damage, and as a result of this, face the need for recurrent antibiotic therapy, recurrent hospital admission, and hence risk of colonization with resistant organisms and infection with resistant organisms. And there's also the matter of the use of other antimicrobials such as chloroquine, which is an antiparasitic agent, in these patients with COVID-19. And this would lead to risk of resistance in high non-Plasmodium falciparum malaria settings. And some countries continue to use these drugs, including chloroquine and azithromycin, for treatment of these patients. And really, even though despite use of these being halted in many settings. They still use them because, of the lack of other treatment, severity of illness, and a general desire to try everything to assist the patient. So in cases where there may be delays in diagnosis, antimicrobials may be started before a diagnosis is confirmed. And so for settings where this is the case, more rapid diagnostics would help to cut down some of the antimicrobial use. Overlapping of symptoms, as I stated the symptoms before, you may have just non-specific symptoms, which this is shared with some other infections such as TB and malaria. And so you may find that you may have, as a result of this, inappropriate prescribing of antimicrobials or lack of prescribing and even misdiagnosis in some cases. So, and all these factors impact future drug resistance levels of other pathogens. As it relates to availability of antimicrobials, the pandemic would have resulted in disruption in supply chains, decrease in exports from countries that manufacture antibiotics because of increased demand in their countries for these agents, disruption in manufacturing of the antimicrobials generally speaking, and changes in usage pattern of antimicrobials. So impacts in lower middle income countries as it relates to availability. So uneven supplies of different antibiotics, you run the risk of AMR due to suboptimal antimicrobial use. They may be forced to use substandard and counterfeit drugs. And of course, you have inappropriate antimicrobial choice and suboptimal concentrations which favor resistance. And in some cases, special infections, specific infections such as tuberculosis, where treatment usually involves use of multiple antimicrobial agents for prolonged periods. If you end up with a shortage of one or more of these drugs, then this could result in treatment failure and hence development of resistance. So financial hardship, the pandemic has resulted in generally lowering of the overall wealth of nations, and fiscal and monetary measures employed to combat the pandemic may increase or decrease the risk of AMR. In high income countries, you have prescription, where you have prescription of, prescriptions required for patients to get antibiotics. You may have the decreased income being associated with poorer health because people are just not able to go in to get a prescription from their physician, but also increased rates of, you end up with increased rates of respiratory infections and increased use of antibiotics for same. In lower and middle income countries, less regulation of antibiotic purchasing, the increased need and use of over-the-counter medications to decrease health expenditure, subtherapeutic doses of antimicrobials, shortened courses of therapy, and with all of this, you have increased mortality due to infection that could be averted with appropriate antibiotics. And these factors enhance selection pressure in favor of antimicrobial resistance. So, infection prevention, looking at the burden of infection in healthcare settings, patients with severe COVID-19 infection are at increased risk of nosocomial infections and exposure to antimicrobial resistant organisms as a result of them requiring prolonged hospital stay. Many of them may require mechanical ventilation or other organ support and use of invasive devices, as well as they tend to get multiple courses of antibiotics, and they can be affected by pathogens including methicillin-resistant Staphylococcus aureus, Pseudomonas aeruginosa, as well as Acinetobacter baumannii. And other risk factors for these nosocomial infections in light of this pandemic would be shortages of PPEs, staff shortages because of self-isolation or increased demand and fatigue on staff. And you may have deployment of inexperienced staff. So the pandemic has led to competition now between patients with COVID-19 infection and those with other colonization or infection with other pathogens requiring isolation. And so you have competition for isolation areas and diversion of PPEs. And to note that antimicrobial stewardship activities can also be affected by this pandemic due to the hardship and resource strain. So you run the risk of increased antibiotic misuse and increased number of infections with antimicrobial resistance organisms overall. There may be even on the other hand though, with increased, all right, let me see. So on the other hand, you may have a positive side of this in that you may also see a decrease in transmission of healthcare acquired antimicrobial resistant organisms with fewer patients in secondary care facilities for other reasons, fewer elective surgical procedures, enhanced IPC measures, and targeted hygiene. And these factors prevent infections overall and contribute to the limiting of spread of AMR by decreasing antibiotic prescribing for infections generally. So as it relates to increased hygiene in the community, so positive effects of the pandemic, we have had the opportunity to increase public awareness regarding infection prevention measures and increase hygiene and food safety measures, which aid in decreasing transmission of zoonotic antimicrobial resistant organisms, and hand hygiene overall, decrease transmission of diarrheal disease, and hence reduce the number of antibiotic courses given for diarrhea. And, however, negative effects would be the increased use of biocides or disinfectants in communities and healthcare settings, which may select for resistance to these agents as well as resistance to antimicrobials overall. In terms of the physical distancing measures and the travel restrictions, some positive effects of this: physical distancing, lockdowns, closure of schools, etc., result in decreased opportunity for transmission of many of these pathogens, including antimicrobial resistant organisms. You can have decreased influenza levels in the population due to, and this will allow for decreased use, inappropriate and appropriate use of antibiotics, decreased number of invasive bacterial infections, such as group A streptococcal infections. Mask wearing decreases the droplet and airborne transmission, and decreased contact outside the home may also reduce TB transmission and subsequently MDR TB incidents. And travel restriction can decrease the prevalence of carriage of antimicrobial resistant organisms. Some negative effects: prolonged time at home can result in increased transmission within the home of pathogens such as TB, multi-drug resistant TB, streptococcus pneumoniae. Onto the healthcare system changes. starting with clinical care disruptions. So some positive impacts would be reduction in inpatient antibiotic prescribing, reduction in elective surgeries and healthcare seeking could result in, once again, reduction in antibiotic use and hence reduction in selection for antimicrobial resistance. But negative impacts, you have disruptions of programs and service deliveries for diseases like HIV, TB, malaria. You have repurposing of staff and diagnostics facilities toward COVID-19 management, and disruption of diagnostics can result in increased time to diagnosis and effective treatment. Patients with antimicrobial resistant organisms may be infectious, and hence there's increased opportunity for transmission of these to other patients. It would take longer to identify outbreaks with resistant variants, and patients presenting less antimicrobial samples. No, pardon me. So disruption in diagnosis would be fewer microbial samples taken, so more antibiotics prescribed without the guidance of culture results, for examples. And also decreased face-to-face support for diseases such as tuberculosis can result in suboptimal adherence, contributing to relapse. So changes in health-seeking behavior in settings where prescriptions are required for antibiotics. You may have a short-term reduction in overall antibiotic usage, which may reduce antimicrobial resistance emergence in the short term, and negative impacts, changes in health and treatment seeking behavior, and potentially difficulties in physically accessing care. Delaying care now could result in worse clinical outcomes for patients, increased rates of hospitalization, need for more different antibiotics. And with introduction of telemedicine, you may have what is called just in case antibiotic prescribing, resulting in increases in antimicrobial resistance. As it relates to vaccination, vaccination is a key tool to preventing infections and resulting in decreased antibiotic use and associated resistance. The pandemic has allowed for some increased coverage for influenza in terms of vaccination in an effort to avoid dual infection in patients. And this also can result in decreased antibiotic prescribing. However, vaccination is susceptible to supply chain disruption, and decreased overall vaccination coverage can occur globally as a result of fear of attending clinical settings or disruption of the routine immunization activities. And lower vaccination coverage can result in an increase in antimicrobial use and thus increase in antimicrobial resistant organism prevalence. And also with challenges with vaccination programs, you can end up with a surge in vaccine preventable diseases and their complications, which once again can result in increased antibiotic use and risk of resistance. So we all have a role to play from the standpoint of healthcare workers. It is important to consider any safe alternatives to an immediate antibiotic prescription, prescribe in accordance with therapeutic guidelines, inform treatment decisions using diagnostic tests where possible. We must educate our patients regarding the appropriate use of antibiotics and resistance. We must also educate them about how to prevent infections and their spread, mainly through good hygiene and vaccination. We must also advise them about management of symptoms without the use of antibiotics where they are not necessary, and always to apply appropriate infection prevention and control measures when necessary. And for the general public, they should only use antibiotics when prescribed by a certified health professional. Always complete the course of treatment. Never share or use leftover antibiotics, and prevent infection by regular hand washing, avoiding contacts with persons that are ill, and keeping up to date with vaccinations. So, in summary, antimicrobial resistance is of major concern worldwide. The COVID-19 pandemic and measures used to combat this pandemic have the potential to have significant impact on the evolution and spread of antimicrobial resistance. And the principles of infection prevention and control, once maintained, play a major role in controlling the spread of antimicrobial resistance. And we all have a role to play, healthcare professionals as well as the general public in the community, in this fight against antimicrobial resistance. So that's my presentation. Thank you for listening.
Thank you so much, Dr. Goff. Your presentation was enlightening, intuitive, and instructive. At this time, we invite Dr. Stemplio to return again to our virtual podium for our final talk from our presenters today before we go into our video segment. Dr. Stemplio's presentation is another important one among this morning's offerings. She'll be talking to us on breaking the chain of infection. Dr. Stemplio?
Yeah, good morning, and apologies for the problem. Technical issues actually was bigger than technical, but now I'm back here online. So thank you very much. I was able to enjoy as well the presentations from my colleagues. And what I would like to discuss with you today is about the breaking the chain of transmission inside of the healthcare facilities, specifically looking at the antimicrobial resistant microorganisms, right? So before we start, just to give to you here where we find the reference for this presentation. So in the PAHO WHO webpage, and this is the core document that I base my presentation today. So we all know, and we discussed today, what are the goals for infection prevention and control at healthcare facility. We work towards to limit human-to-human transmission, increase the safety of the patient at healthcare facility as well, the healthcare workers, and prevent transmission through amplification or super spreading events. And we have, from many years now, seen in healthcare facilities outbreaks of the super bugs or multi-drug resistant microorganisms. Many patients involved in the outbreak, many cases, and also many deaths, unfortunately. So it's something that is happening, and we have tools to prevent it. Dr. Shaw show us how effective those tools can be, and I will go a little bit more in depth for specific tools for prevention of multi-drug resistance microorganisms. So Dr. Reynolds Campbell told us about the how many microorganisms we have, and that in all our systems we have good and bad microorganisms. So microorganisms that are here to help us, and some that can cause some diseases. And those diseases can be community acquired or can be healthcare acquired. And our focus is to see how we can play our role to avoid the healthcare acquired community infection, sorry. So what is the basic chain of transmission of healthcare associated infection? So we have a patient, usually the patient is the main source. The patient is sick, the patient has an infection, and this patient can transmit to healthcare workers. The infection or healthcare workers can become colonized even for a short period of time. And this healthcare worker can then transmit to another patient or the patients can have contact between them or contact with the environment that was not properly cleaned. So the chain of transmission inside of the healthcare facility have the same links that we have for the chain of transmission in a community setting, right? We have the reservoir, we have the place of exit, we have mode of transmission, places of entry, and also the susceptible host. But there is a special importance for us in a hospital and healthcare facilities about the mode of transmission, because we know strategies to prevent and break this chain in the mode of transmission in the healthcare facilities. So mainly we have two sources of microorganisms or colonizations and further infections. One is the endogenous source, that the agent is part of the patient flora. Once the patients start in treatment with antibiotics, the antibiotics select resistant microorganisms, and then those microorganisms increase in number and can cause infections. Or we have exogenous source that comes from or stay in the environment or hands from healthcare workers, and then people get colonized and have infections from exogenous source in the healthcare facility. So what are the ports of exit and mainly the entry ports? Respiratory tract, gastrointestinal tract, genitourinary, skin, and also blood and body fluids. We know that in a facility, we not only manipulate and do procedures in all these systems, because this is what we are intend to restore the functionality, but also many times we break the natural resistance or natural protection that those systems gave to us. So we intubate the patients, we put nasogastrointestinal tubes in the patients, we put urinary in the valley catheter in the patient. So we perform many procedures that breaks the natural barrier that our body has against the infection. So it's something that we need to have in mind, because when we do that, we need to do it in a way that we are not causing harm and we are not allowing infections or colonizations to occur and infections to occur. For multi-drug-resistant microorganisms, we have mainly two modes of transmissions. In a hospital, in general, we have more, but here I will focus in these two modes of transmissions. One is contact mode of transmission, that it can be direct contact, person to person, physical contact, or indirect contact through fomites that we learn a lot about that during this pandemic, and it's also very important for multi-drug resistance. And then we have also droplets that for some types, such as multi-drug or methicillin resistant Staphylococcus can occur, and that it can colonize the environment through coughing or sneezing of people who are colonized in the respiratory tract. So how it's occur? You have a patient, you see here the representation, the patient is sick, of course, not only the patient, all of us, we have germs present on our intact skin. So the skin and the contact with the environment colonize the environment around the patient. So we have the patient, and these purple dots are the representation of the microorganism. And then everything around the patient become contaminated. And also, as Dr. Shaw mentioned, the hand hygiene need to be performed after the environment, because the environment is usually also colonized with microorganisms that are present in the patient who are in bed. Of course, the number of pathogens and the counts can vary from patient to patient, from microorganism to microorganism, and also from environment characteristics. But the environment around the patient get colonized. Then we have the healthcare worker who comes very close to provide care, right? All the healthcare workers, all type of healthcare workers come close, touch the patients, touch the environment. Of course, the risk for colonization of hands, for example, that may be different, depends on the type and duration of the patient care. But important to us to know that the gloves contamination is similar to the hands contamination. And clean activities such as lifting patients or taking the patient's pulse can contaminate the hands with 100 to 1,000 colons of Klebsiella, for example. And in general, we cares or healthcare workers cares in their hands microorganisms that can cause infections. Then we have our hands with microorganisms, transitional or transient colonization, and the next step will be perform hand hygiene. However, in our hands, these germs can survive, and sometimes they can also increase in number. So what we need to do is do proper hand hygiene. We know that looks simple. We know that everybody should master hand hygiene, but we also know that not always people do it properly, and not always that people need to do it, they do it, right? So many factors, insufficient amount of product, insufficient duration of hand hygiene, we can have poor hand hygiene decontamination, and the microorganisms that transitant are there, they can recover, and then we have the inoculum from one patient to another due to the lack of hand hygiene or poor hand hygiene of the healthcare workers. So then the microorganisms go from patient A for patient B, and it's caused by, for example, poor hand hygiene. So in summary, the factors that are related with the colonization of susceptible patients in there, that we have the colonized or infected patient that share microorganisms and colonize the healthcare worker's hand or the environment. So if we don't have proper hygiene of environment or hand hygiene, those microorganisms will be able to reach the susceptible patients. So the way that we have to avoid it, as simple as Dr. Shaw mentioned, is the standard precaution. Standard precaution will be able to cut all this chain of transmission in the healthcare facility. But of course, there are risks that are risk factors that are related with patients, specific, that are age, severity of the illness, medical condition, immunosuppression, and others. However, against those risk factors, we have a few to do, but we have a lot to do about the factors that are related with our daily work, daily care for the patient. That will be how we proceed doing invasive procedures, surgical procedures, use of antibiotics, invasive device, the length of the hospitalization, and also healthcare worker process factors such as poor hand hygiene, lack of use of barriers, environmental contamination, crowding nurse-patient ratios, and prevalence of pathogens. So those are factors that we can work to improve. And then break the mode of transmission of those chains. So Dr. Shaw already showed this. It's very important to everybody have it in their mind and in their heart, because we know that we need to use bundle of measures, different measures, to be able to break the chain of transmission. So, and specifically for mold drug resistance, we are using elimination through cleaning environment, engineering control to isolation areas, administrative controls for cohort, for example, of patients, and use of PPE. So standard precaution is the base. We already discussed it. Just as a reminder, everything that I'm talking now is over a standard precaution. So we apply standard precaution, you do the risk assessment, and over that, we apply or implement specific measures to break the chain of transmission for mold drug resistant microorganisms. So I mentioned to you that mold drug resistant microorganisms are transmitted by contact. So we are applying measures to prevent the transmission through contact. What are those measures? So first one will be place a patient in a separate room or a room with other patients who have the same agent or diagnosis, right? In this case here for mold drug resistance, the same agent. So we have to have the PPE available to them to use. And this PPE need to be in the entrance of the room or nearby if you have a cohort, nearby the entrance of the cohort to make sure that every healthcare worker have put the PPE on before contact with the patient. And if you are transferring the patients, everybody who are involved in this transfer need to wear PPE as well to protect themselves and to avoid transmission to other patients. What the PPE is recommended, what type of PPE is recommended to contact precautions? Gowns and gloves, right? So nowadays, because of COVID, we are all wearing masks. And based on the standard precautions, based on risk assessment, goggles may be or may be not needed, but gowns and gloves are needed because we can colonize our body and hands with the mold drug resistant microorganism if the patient is colonized or infected. And another one will be droplets for specific types of mold drug resistant microorganisms, and droplets will be use of mask if close contact without COVID. In COVID era, now everybody is wearing mask. We need to have place the patient as well in a separate room, protect facial mucosas, and use goggles or face shield based on risk assessment. And during transfer, we need to wear mask and put mask in the patient as well. But important here will be use of mask, gloves, and gowns as well. The general principles were already mentioned. Hand hygiene always need to be performed. Remove and replace if it's necessary, if there are any damage or broke pieces in the PPE. And what we are seeing, and Dr. Goff mentioned that, what we're seeing is increased number of cases of mold drug resistant outbreaks in a hospital, especially in a cohort of COVID-19 patients, because of misuse of PPE, and people do not change the PPE between patients. So we remove all PPE as soon as possible, and then discard all PPE carefully and perform hand hygiene. So the cohort is one of the administrative measures that we need to be in place to break the chain of transmission and to facilitate the care of patients with mold drug resistant microorganisms. So we use our resources in a cost-effective way. We are applying the same PPE measures for the whole group of patients with the same agent. So we will discuss more and more, and the mechanisms of resistance are quite complex and they are interchangeable. So some microorganisms can host more than one mechanism of resistance and become more and more challenged to cohort the patient. So the IPC team need to have a clear guide how they will cohort the patient. So I will cohort all the patients with, for example, KPC, one type of microorganism, antimicrobial resistant, together, but I will not put these patients with microorganisms producing KPC together with another multi-drug resistant microorganism, for example, Enterococcus resistant to vancomycin, to say something. But it is important to have these policies in place and cohort the patients with the same agents and the same mechanism of resistance. And it also can, it's also important that all the resources, not only the space, need to be, exclusive for the cohort, such as much as possible, the healthcare workers, equipment, and other resources that are used there. If you cohort the patients, that will make easier for, the institution to make supervision of the care that is provided for these patients, and also guarantee lower the spread of this type of infection in the healthcare facility. And finally, also was mentioned by Dr. Shaw, is the importance of cleaning and disinfection of environment for healthcare associated infections caused by multi-drug resistant microorganisms. It is also very, very important. We have reported in the literature that microorganisms can survive up to 8 months in an improper cleaned environment. So it is important to keep it in mind that isolation area need to be cleaned and disinfected. Dr. Shaw also mentioned that we don't need to clean everything with the same frequency, but the high-touch surface around the patient area, because it will be colonized with those microorganisms, it needs to be cleaned very frequently. So in summary, the multi-drug resistance microorganisms are transmitted by contacts and droplets, and we know the measures, right, to prevent this type of transmission. Hands of healthcare workers and fomites play an important role in this chain of transmission. It's also proven that those are the most important ways or mode of transmission, contact for multi-drug resistance microorganisms. It's standard for everybody, and additional precautions, contact and droplet precautions, are efficient to limit the spread of multi-drug resistance. We know that many outbreaks were controlled using those simple measures that we discuss here today. So if it is implemented, successfully implemented, and people assess the efficacy, you see that it is efficient to limit the spread of multi-drug resistance in healthcare facilities. We need to apply a group of effective controls as a bundle. We need to apply controls that we will eliminate, such as cleaning and disinfection, engineer controls, such as isolation area, administrative controls, such as cohort of patients, and use of PPE, altogether to effective control and mitigate the spread of multi-drug resistance and outbreaks inside of healthcare facility. So this is my last slide. Thank you very much for the audience, and I'm so sorry about the problem that I have at the beginning. Thank you.
Thank you so much, Dr. Sempliuk. I know some of these technical challenges are beyond our control at times. That was another interesting and expertly delivered talk. Thank you so much. So now we have a few minutes for question and answer. We're a little over time, but I do believe that we can take a few questions. So we are still inviting questions in the Q&A box, or if it is more convenient, you can post it in the chat. I have a question, which I will direct first to Dr. Sempliuk, but I invite comments from our other panelists as they are so led. I know that it is important to have evidence, and evidence that's coming from the local setting to drive policy, to drive the implementation of some of our strategies to combat this problem of antimicrobial resistance. To what extent do you guys think more needs to be done to make the collection of data on AMR, on IPC strategies more systematic, and to increase access to and the availability of funding, grant funding that can be prioritized for local research? Dr. Sempliuk, and again, I invite comments from our other panelists.
Thank you very much for the question. We do also have another question here. So I really advocate for always we show the problem that we have, right? And in this respect, Dr. Clindy told us about the importance of surveillance, because this is, if you're not able to show that we have a public health problem, what are our levels of resistance, then it will be difficult to convince policymakers and decision-maker people who deal with many, many different priorities, right? So it's not that this is the only one that they have, that we actually have a problem. So this is my number one, I think, message. We need to be able to, count what is happening and make advocacy based on data that it is a problem. So when you see the numbers from, for example, US that were shown today, so it's something that impacts, right? Because we see these 32,000 people or, have infected by multi-drug resistance, and then each one of they stay 7 days more in a hospital. It's easy to everyone to quantify how big is the problem, right? So this is, I think, is my my first thing. And then once we have it clear and we know, we can then cost and say we need so much money to tackle this problem. What we learn is that prevention is always much less costly than treatment, right? And infection prevention and control, and some papers published shows that for each dollar that you invest, you save $7, right? So it's very cost effective, and we need to start to show it for our policymaking people. So some countries who have the long-term surveillance, they can show how much they prevent and how much money they save. And usually the infection prevention and control program are very, very cheap. We don't cost a lot. So many strategies can be done. So, but for example, a very practical and simple one, we have many beautiful papers published showing the efficacy and the cost saving, for example, for better antibiotic prophylaxis for C-section. So you keep it simple, you do one dosage, we don't keep the treatment after, and then you avoid resistance and you save a lot of money without extend the antibiotic prophylaxis, for example. There are many strategies that can show immediate effect and bring the awareness of the level of the decision maker.
Okay, thank you so much. I agree with you, Dr. Sempliuk, and you gave a very comprehensive response. So I suspect that there may be no further comments there, but of course, if our other panelists want to respond, they can let me know. There's another question for you, Dr. Sempliuk, from my colleague, Andrea Fagan. She wants you to comment or to speak a little bit more about how blood pressure cuffs can be cleaned and disinfected.
Okay, so first of all, blood pressure cuff need to be just cleaned, because going a little bit further, it will be no critical, right, article. So we don't need to disinfect. So the very good water and soap can help us on it. So we can, so if it's a linen one, we can throw the part that go in the arm, we can send it to the laundry and they can wash it for us, launder it for us. And the other part that usually is plastic, right? Or the cuff, you can, water and soap and clean it like we will probably clean other surfaces that are with blood. The problem will be if water go inside, and that may be, so we don't need to soak it, but we can clean with, a rug and soap and water. And actually this is a good practice because beside of when it is dirt with blood, people may clean it or think about cleaning it, but there is no routine cleaning of this. And this is one of the devices that we need routinely clean as well. Over.
Okay, guys. Thank you so much, Dr. Stempliuk. I'll just allow 1 minute more. If there's another burning question, this is your last opportunity to hear from our expert panelists. This last question is primarily directed to Dr. Goff, but again, other presenters can indicate if they'd like to comment as well. We've heard a lot about AMR, about the importance of IPC in combating this problem, and how COVID-19 has entered the arena and has had both positive and negative effects. It would seem to me that in order to harness more of the possible positive effects of COVID-19 on AMR, we need an enabling environment where we have adequate staffing and ideal bed occupancies. Dr. Goff, can you speak to the challenge of maintaining adequate staffing, an adequate cadre of nurses, cleaning staff, which often, their turnover rate is often very high. Can you comment on this? And I don't know if you have any solutions. I know it may be challenging, but can you comment on this problem? Staffing.
Dr. Tom?
Okay.
Hi. Okay.
Go ahead, Dr. Goff. I was just going to preface the discussion. But go ahead, Dr. Goff.
Well, you could go ahead, Dr. Shaw. That's fine.
Okay. So, yeah. Morning again, everyone. Thanks, Dr. Tom.
Sure.
I mean, I think we have to take this discussion twofold. There's a section of it which, under the guidance from the Ministry of Health, that retention discussion, expanding your workforce, looking at your resources and sort of doing a sort of succession planning to understand how many persons you need on board is something that I don't know if the panelists here would necessarily be able to comment on. We understand the importance of it, and we can suggest how many persons, in terms of keeping the services viable. We can suggest what is or look at the standards and tell them what is required. But that is something that probably goes way up. Having said that, though, the other arm is looking at certain things, the things that we can control. We talk about the opportunities for training, standardizing, putting out the SOPs. Those are the things that we must ensure, and we can definitely make an impact. So the cross-training, ensuring that the proficiencies and the practices are standardized across the board, familiarizing, not only the patient, the families, all these things. These are the opportunities that we must look at. And I believe this is how you keep the levels up. You get the interest across the board of persons who want to have this, want to target this vested goal, and therefore, it will help us keep it and sustain it. I don't know if we can necessarily speak to how we retain staff. like that. What we would do is whoever we have, we cross-train, we expose, we standardize what it is that we're training. So everyone is doing the same thing. We minimize exposure. So we do mitigation. And I think this is how we would approach the question, what is within our portfolio and what may be out. So we, as a technical expert sitting here, we have given forward what is required. And then we tackle what we can. So back to you now, Dr. Thomas. Thanks.
Thank you so much for that, Dr. Shaw. And Dr. Love, I don't know if you wanted to add to Dr. Shaw's comments, or did it answer the question sufficiently for you?
Yes, Dr. Shaw covered it well.
Okay, awesome. And I just think that advocacy on many levels does go a far way, you know, and yes, sometimes we're not always able to get the ideal, and so we do have to make do with what we have. So that brings us to the end of our Q&A segment. Dr. Goff, the person's already asking for copies of your presentation. You know, the responses were underscored by various persons in the chat about different things. And so we thank you for all the comments and feedback. Dr. Shaw?
Right. Thanks again, Dr. Thomas.
Sure.
There was a comment about, is there any other way to aid the development of policy of addressing AMR other than providing data? I thank you for the question, Georgette. I would say to you, you know, it's going to be very hard. It's a hard sell. People believe more in what they see than what they hear. I think a lot of times we have been lobbying, we've been talking, we've been discussing for quite some time. And until you can give them evidence where it is tangible. I mean, they are seeing some of the rewards now, you know. With the introduction of COVID, we've had many topics that have been brought to the fore. So we don't have to do a trial. We don't have to sit down and do a research study. We've seen the impact of the pandemic. We've seen how it is going to affect AMR. We know that it has positive and negative, if you want to say, aspects of it. And therefore, we see also the value of some of these conversations, even, you know, centered around infection prevention and control, having everyone on the same page, standardized, the need for policy. So we are gaining some traction in some regard, and therefore this has been very helpful. But to truly, you know, sort of contextualize the problem of AMR, I believe the only way we can get it, you know, let it have some, if you want to say, use the catch term, teeth, is by providing the data. And that in itself is a mammoth task. And we continue to chip away at it. As was said, I think the previous question about how you approach it, we were, from the ministry's standpoint, you know, this discussion of the surveillance for these infections, the healthcare associated infections, is something that we wanted to start. Of course, the introduction of COVID has put us a little bit further behind than we would like. But we are still looking to resume this, and we have many other discussions of policy that we would like to put online, you know, or bring online in order for us to further our journey in proving that AMR is a serious situation, especially in our context. So that's the response to the question. Over to you, Madam Chair.
Thank you. Thank you so much, Dr. Shaw. And I just want to acknowledge Georgette Thompson's response to your earlier comment that training and cross-training is indeed important and should be continuous. And she does commend the team for efforts to sensitize the public. But she comments that we need the input of all major stakeholders and resources to ensure the word lingers in the ears of the public. Her final question, which is our final question for the morning, is she's really wondering about feasibility of research and drug development in Jamaica. And she wonders whether persons here are competent. I do know that we have persons competent to do different kinds of research. I think perhaps a major limitation is funding, but I'll also throw the questions out to the panelists, and this will be our final question for the morning.
Okay. Well, I will start off, I guess. I'm not completely clear on the question. From what I've read, I think we're discussing about our capacity as a country to develop, for example, medications, drugs. Is that what it is? I don't know. Maybe she can ping and sound off in the chat if that's the question. Yes, that's it. Okay, great. Well, you know, we are classified as middle income. So we start there. And there's a bit of capacity that is available. But if you have looked at the mechanism, the machinery, which is what we want to start with, the machinery in order for you to pursue some of these avenues to develop, whether it be antimicrobials, even vaccines, you know, it takes a lot. There has to be some sort of investment in these sort of machinery, understanding full well that you need not only the persons that are going to drive the discussion, but you have to have some sort of regulatory framework. So there are a lot of missing components, I would say, in country. We don't have it isn't as if we don't have persons, as Dr. Thoms had rightfully said, who can undergo or can conduct research. But there are other things, and we can't list or name all of them, but let's just take it at face value that there are missing parts. Now, as we continue to progress, technology and the opportunities may present themselves. You never know. It might be a small start along the way. And as such, we take it, you know, it's like watching a child grow up. But at this time, we don't have the capacities at all levels when you think about what is needed to actually undertake this sort of process. And it's something that we continue to struggle with. As I said, you have persons who may want to be innovative and they, you know, will express interest, and these opportunities sometimes fall to the side. But the ministry, I can say we are discussing a lot of it. We have been faced with these discussions prior. We know where the gaps are. As I said, there are many players in the discussion, so it's not just about the Ministry of Health in this one. We would form part of the regulatory body, and that in itself is a full challenge because the limitations in staff and expertise to do the monitoring, the evaluation, the registration, all of those things you have to think about. So, you know, we can say definitely we don't have the capacity. The spirit may be willing, but honestly, the body is just not going to be able to work with the spirit on that one. So I hand that back to you. If there are any other comments, I don't know, maybe from the other ministry side, maybe they have more opportunities. Dr. Miguel or so, anyone?
Okay, thank you, Dr. Shaw. Well said. And I just want to underscore that, you know, we really do need to try to push for more resources because there's some very low-hanging fruits. The Ministry of Health is having its conference, and there are presentations on work done on AMR, and there are persons who have tried to explore antimicrobial properties of various compounds, which could be patented, and there can be collaboration. So there is scope, but definitely I agree with Dr. Shaw that there are many gaps still that remain, and we really do hope that, you know, eventually we will get to where we need to be. So thanks to everyone. Thank you for all your questions, your participation. Thank you to all of our panelists for their talks and for their responses. It was a feast of knowledge that was shared this morning. We will now have a brief video segment, after which I will return with closing remarks. Videos will be shared that further highlight the importance of judiciously using antibiotics, including the role healthcare workers can play. The interplay of COVID-19 and its potential impact on AMR will also be highlighted. There are 3 short videos, less than 2 minutes, and they're quite interesting. So please stay with us, and then I'll return with closing remarks.
Antimicrobial agents are specific drugs meant to treat infections caused by bacteria, viruses, parasites, and fungi leading to diseases in human beings, animals, and plants. Such drugs are prescribed and/or administered by physicians, veterinarians, or agricultural engineers. The element of surprise is very important for antimicrobial drugs, as their opponents must be unaware of their upcoming movements. If we take these drugs when they have not been prescribed, we are inflicting a potential problem to our body, and when the true threat comes, these drugs will be less effective. This phenomenon is called AMR, Antimicrobial Resistance, which means that the drug is no longer effective against that microbe. Antimicrobial resistance can be prevented if we avoid self-medication and early treatment discontinuation, and also if we avoid eating food products of animal and plant origin containing antimicrobial drugs. Resistance to antimicrobial agents poses an ever-growing threat to public health around the world and calls for urgent measures. Help in upholding the efficacy of antimicrobial agents by using them only when prescribed by a qualified professional. Talk to your relatives and friends about the importance of a proper use of these agents and the problem derived from antimicrobial resistance. Resistance to antimicrobial agents is the capacity developed by bacteria, parasites, viruses, and fungi to resist the effect of drugs designed to fight them. This is a process occurring naturally through genetic mutations. However, this phenomenon is accelerating at an alarming pace as a consequence of the use of antimicrobial agents due to unnecessary prescriptions, self-medication, early treatment discontinuation, their use as additives for livestock fattening. These factors have turned resistance to antimicrobial agents in a growing concern for public health authorities worldwide, making it more difficult to treat many diseases such as tuberculosis, malaria, HIV, sepsis, diarrhea, and pneumonia. As health workers, we have a leading role to play in fighting this problem. By fostering the prevention of infectious diseases, vaccination, hygiene, by prescribing these drugs in a responsible manner, by monitoring their use by the patient, and by bringing awareness to the population around the dangers involved when abusing their use. Each one of us has a role to play in fending off resistance to antimicrobial agents. Lately, many things have changed. The way we greet each other, our personal items, meetings with friends. We changed, of course, but we're still the same. During this pandemic, information is our main partner. That's why today, let's talk about resistance to antimicrobial agents and COVID-19. Drugs used to treat body infections are called antimicrobials. But if you take them when it's not appropriate, they lose their efficacy, and when the time comes that you really need them, they will no longer be useful. This phenomenon is called AMR, Antimicrobial Resistance. The most widely known antimicrobials are called antibiotics, but they are useless to fight diseases such as COVID-19 because it is caused by a virus, whereas antibiotics cure diseases of bacterial origin. Therefore, if you feel sick, do not self-medicate. Consult a health professional qualified to write a prescription and take antibiotics only when prescribed. COVID-19 and antimicrobial resistance. Key information for a better world.
Wonderful. Thank you. We've had a feast of knowledge today. Dr. Sempliuk started us off by reminding us of the role that various agencies have been playing to increase our awareness of the problem of AMR and how we can use strategies to break the chain of infection. Dr. Reynolds Campbell spoke about the global impact of AMR and the fact that this is a problem that can affect development globally. Dr. Shaw reminded us of IPC strategies that can be used to help prevent the spread of AMR. And Dr. Goff enlightened us about the impact that COVID-19 has had on this problem. She pointed out that there are potential positive and negative effects. It's up to us to try to harness the positive effects and to minimize the negative effects as much as we are able. This is something that I hope we will not just hear about today and leave it as, interesting information, but we'd really try to apply it to our daily living and to spread the word. Everybody needs to hear about this. Everybody needs to be reminded about using antibiotics wisely and carefully. And we see that there are nice videos that we can share, and Dr. Sempliuk has posted other resources and links that we can all share to help raise awareness. I thank you for staying with me, and just allow me a little more time to just thank the many persons who helped to make today's session possible. Many thanks to the conference and World Antimicrobial Awareness Week organizers. This was a collaborative effort of several organizations, including, but not limited to, Government of Jamaica, the United Nations, the Pan American Health Organization, the Ministry of Health and Wellness, the Ministry of Agriculture and Fisheries, as well as the Ministry of Investment, Industry and Commerce, Jamaica, colleagues from the UWI. Special thanks as well to our 4 presenters, Dr. Sempliuk, Dr. Reynolds Campbell, Dr. Karen Shaw, and Dr. Rhea Goff. They all delivered expert talks and excellent presentations. Many thanks to everyone who played a role, and last but not least, thank you to you, our audience, especially to those of you who stayed until the very end. We want to just encourage you again to stay safe, use antibiotics wisely. CMEs are not on offer, but we can give certificates of participation. You just need to register and indicate your interest. Dr. Shaw has also reminded us that the color for the week is blue. So if you can, please don your blue apparel. All right, thank you all and take care. Have a wonderful rest of the day.